role in red blood cells, sequestration and immunity, storehouse of platelets, produces RBCs and WBC in fetus during gestation period and sometimes in adults. If we go in the anatomy of the spleen, it develops from the mesenchymal cells in the dorsal mesogastrium during the 5th week of gestation. Located between 9th and 11th ribs of the left side, and it is about 14 centimeter in length, 7 centimeter in breadth. Weighs about 150 to 200 grams. Accessory spleens called splenectomy. The importance of splenectomy we will going to discuss once we do the splenectomy, or we will discuss the splenectomy. There are 4 ligaments which are attached to the spleen. One is the gastrosplenic ligament, which is between the spleen and the stomach. Linorenal, which is between the kidney and the spleen, and linophrenic, which is between the diaphragm and the spleen, and spleenomegaly, which is between the spleen and the colon. Blood supply: splenic artery, short gastric arteries, veins, splenic vein. You can easily see you can well recognize the arterial supply and the venous supply in this picture. Red pulp of the spleen, it is 90%, and cords and sinuses. Its work is phagocytosis and open circulation. White pulp, articular lymphatic sheets and immunoglobulins. Functions of the spleen are cellular, pitting, culling, storage of the spleen, phagocytosis, iron reutilization. Immunological: synthesis of IgM, lymphocytes, tufts, opsins, proprotein and interferon. Hypersplenism. Hypersplenism is the condition in which the spleen becomes increasingly active and then rapidly removes the blood cells. So hence the splenomegaly occurs, and in those patients where the hypersplenism is there, pancytopenia or a reduction in the number of the one or more types of the blood cells, maturation arrests, decreased red blood cells survival, decreased platelet survival. Normal spleen is not palpable, as we can easily recognize in a normal patient, where we won't able to find anything, any bulge beneath the left costal margin. Once the size is 2 to 3 times the size of the spleen, it gets palpable. So it means you will be having a palpable spleen in a patient who is having a 2 to 3 times the size of the spleen. And the way, if it is 400 to 500 grams, then only you can able to appreciate the spleen as an enlarged organ. Spleen size is not a reliable indicator of spleen function. Clinical features: mass in the left hypochondrium, notch which is palpable. This is one of the differentiating point between the any mass which is other than the spleen. Supposingly the same mass which is arising from the colon, it won't be having any splenic notch, a notch palpable. If the mass is in the colon, left splenic fracture, you can able to insinuate your finger between the costal margin and the mass. However, you won't be able to do that in the cases of spleen. It moves with respiration, it is dull on percussion, direction is towards the from left to right iliac fossa, so left hypochondrium to the right iliac fossa. However, the other masses like the retroperitoneal masses or the colonic masses, it won't follow this track, so they may enlarge downwards directly to the left hypochondrium, to the left iliac fossas. However, the spleen has a typical direction from left to right, left hypochondrium to right iliac fossa. Hook sign. This is also one sign which can able to, you can hook the spleen, and you cannot insinuate your fingers under the left costal margins. Causes based on pathological mechanisms divided into increased function, abnormal blood flow, and infiltration. Increased function: removal of defective red blood cells like spherocytosis, thalassemia, hemoglobinopathies, nutritional anemias, and early sickle cell anemias. All these are related to the increased function, and because of the removal of the defective RBCs, the different shapes or the morphological changes of the red blood cells causes the increased function, which leads to the hypersplenism. Immune hyperplasia: response to infection like viral, bacterial, fungal, parasitic, mononucleosis, AIDS, viral hepatitis, subacute bacterial endocarditis, bacterial septicemia, splenic abscess, typhoid fever, brucellosis, leptospirosis, tuberculosis, histoplasmosis, malaria, leishmaniasis, trypanosomiasis, disorders of the immune regulation, rheumatoid arthritis, systemic lupus erythematosus, SLE, and serum sickness, autoimmune hemolytic anemia, sarcoidosis, and drug reactions. All these conditions can cause the hyperplasia and increased in the size of the spleen. Extramedullary hematopoiesis, myelofibrosis, marrow infiltration by tumor, leukemias, and marrow damage by radiation toxins. Abnormal blood flow: organ failure like due to cirrhosis, it could be vascular like hepatic venous obstruction, portal vein obstruction, Buchiari syndrome, and splenic vein obstruction. Infections like hepatic schistosomiasis and hepatic echinocosis. Metabolic diseases like infiltration due to the Cotter's disease, Niemann-Pick disease, alpha mononucleosis, Hurler's syndrome, amyloidosis, and Tenggier's disease. Benign and malignant infiltrations, leukemias, acute, chronic, lymphoid and myeloid, lymphomas, Hodgkin's, non-Hodgkin's, myeloproliferative diseases, metastatic tumors like commonly melanomas, histiocytosis, hemangiomas, lymphangioma, splenic cyst, hematomas, eosinophilic granuloma, and littoral cell angioma. So these are, different conditions which can lead to the infiltration of the spleen with the malignant cells or the malignant diseases. Causes of massive splenomegaly. This is the condition which needs a surgical intervention. Your patient, if is having a massive splenomegaly, almost whole of the abdomen is filled of spleen, so your patient will be having a discomfort, would be having abdominal pain, the whole of the abdomen, a bulky abdomen. So all those conditions needs the splenomegaly. So these are the conditions in which you have a massive splenomegaly, and that is leishmaniasis, Kala-Azar, chronic myelogenous leukemia, myelofibrosis, malaria, and primary lymphoma of the spleen. Splenectomy indication. There are few absolute indications in which the bleeding varices due to the splenic vein thrombosis, hereditary spherocytosis, massive splenic trauma, and primary splenic malignancy. As we know, all these conditions have needs splenectomy, but especially a massive splenic trauma where the patient is hemodynamically unstable needs an urgent laparotomy. We're going to discuss this in detail later. Relative splenectomy indications are autoimmune hemolytic anemias, hypersplenism due to portal hypertension, ITP, idiopathic thrombocytopenic purpura, leukemia, chronic myeloid leukemia, lymphoma, primary hypersplenism, myelofibrosis, sickle cell disease, splenic abscess, staging of Hodgkin's lymphoma, thalassemia, thrombotic thrombocytopenic purpura, and radical gastrectomy involving the removal of the spleen. As we have discussed in this thing, the gastrectomy, in the carcinoma of stomach cases, where we are going beyond the N2 dissection, like N3 and N4 resections, we need to remove the spleen as well, along with the whole of the lymph nodes which are along the vessels. Preoperative preparation, like all the cases where you wanted to go or you wanted to do the splenectomy, your patient should be optimized. Your patient should be having a grouped and typed blood, cross-matching. The platelet should be arranged, should be administered pre-operatively, should be in hand during the surgery, because during the surgery your patient might need the platelets transfusions, especially with the idiopathic thrombocytopenic purpura patient. In myeloproliferative disorders, administer low-dose heparin as well, 500 units twice daily, and aspirin on the day before the surgery, and to continue this regime for 5 days post-operatively. Vaccines against the Streptococcus pneumoniae, Haemophilus influenza, type B, Neisseria meningitis, administered 14 days before operation. Orogastric tube is used during the operation. Now these vaccines are very important, because your patient would be, after the surgery of a splenectomy, would be vulnerable for the streptococcal infections. So for those patients you need to give these vaccinations prior to the surgery. Now, what are the types of the surgeries, and how you are going to diagnose your patient before the patient who is having a splenomegaly? Now, if the patient, you will going to take a detailed history, and doing the examination you can able to appreciate your patient is having a splenomegaly, and whether your patient is coming in a group of absolute indication or in a relative indication, you are going to judge according to that, and then you are going to operate your patient. But very importantly, your patient who is coming with a surgical trauma, blunt abdominal trauma or a penetrating trauma, so in those cases you need to, especially in the cases of blunt abdominal trauma where the splenic trauma is highly, you can say the patients are prone to develop the splenic trauma, the solid organs, especially the liver and the spleen, going to rupture. So how you are going to diagnose? First of all, obviously you need to follow the ABC protocol of primary trauma care of your patient, or ATLS protocol. On the basis of that, first of all you are going to assess the airway, breathing and circulation. After maintaining these three things, you are going to see your patient is optimized with the or resuscitated with the IV infusions or the blood or not. If your patient, even after an adequate resuscitation, is not responding to your resuscitative measures, it means your patient need a further treatment. It means your patient might be having a splenic trauma or a liver trauma. So in those cases, how you will going to assess? So first of all, the most important is the clinical examination. If your patient is having a bruising on the left side of the chest, if your patient is having a broken ribs, lower especially from 9 to 11th or 12th rib, if these are broken during the trauma, and that is there, if the crepitus is there on the left side, if your patient is having a difficulty in a breathing, and on the left side there are bruising, and there is one sign which is called a Keher signs. If your patient is along with all those findings which we have discussed, having a pain in the left shoulder, you can think of your patient is in a state of splenic rupture. Now, spleen could be traumatized or having a trauma of the spleen during the blunt abdominal trauma with grade 1 to 5. So it depends on the your grades of the injury of your trauma. You assess your patient and you do the splenectomy, especially in the stage 4 and 5 where the spleen is shattered or where the splenic vessels are injured. Now, the types of the surgery are open, laparoscopic, and the thoracoabdominal approach of the splenectomy. You can give the obviously this you can do the open splenectomy by general anesthesia. Position should be supine. You can give the left subcostal or a midline. In case of trauma, you have to give the midline incision, or in case of non-traumatic spleen, you will do the left subcostal incision. First of all, you have to mobilize the spleen. So mobilization is of the spleen to the midline by division of the lateral and the superior pole attachment. The splenocholic and splenorenal ligaments at the lower pole are to be divided. You can see in the picture that the diaphragmatic attachment of the spleen is being cut by this in this figure. Yes, in this picture you can see the splenic vessels are isolated. Once you can able to isolate the vessel, you can have a double ligation of the suture to the vessel and then divide the splenic vessel. Tail of the pancreas is displaced medially to avoid the injury of the spleen, injury to the pancreas, and splenic hilum is held in a way like this is shown in the picture. Spleen is held in the lienorenal ligament only. Spleen is held by the lienorenal ligament only. A nylon bag is used to retrieve the bag brought near the epigastrium. This is the case where you are doing the laparoscopic splenectomy. You know, nowadays, as you know, every type of surgery could be done by the splenectomy, by the laparoscopic procedure, depending on the situation. Mostly the spleen which we are doing in an elective procedure, we are doing the laparoscopic method, but the traumatic spleen should be removed by the open method, because you don't know how many other organs along with the spleens are damaged. So that could be assessed properly by the laparotomy, and you can assess the rest of the organs, like along with the spleen you can able to assess the liver, the colon, the small intestine, and rest of the structures, kidneys as well. So in traumatic cases it is advisable to do the open splenectomy. However, in the cases of elective cases, like as we have discussed, the cases in which the relative or the absolute indication of splenectomies are there, in those cases we can choose between the open or a laparoscopic procedure. The laparoscopic procedure is always a better procedure because of the less pain post-operatively, because of the less complication of the respiration, and the atelectasis, the chances of atelectasis would be less. There would be more acceptable scar. There would not be a linear scar. Patient would be having only 2 or 3 or 4 5 and 10 millimeter small incisions at different places, and by which the port could be passed, and then you can able to do the splenectomy. And post-operatively, the chances of adhesion would be less, the chances of intestinal obstruction would be less, the chances of the wound dehiscence and the wound complication would be less, because it is having the laparoscopic procedure would be having a smaller incisions and acceptable incision. The early resume of activities, the less hospital stay, the less chances of deep vein thrombosis and pulmonary embolism in the cases where you perform the laparoscopic procedure as compared to the open procedure. So the best method to do the splenectomy is the laparoscopic method of doing the laparoscopy, splenectomy, rather than the open method. So this is the way that you can brought the spleen out by a nylon bag to retrieve the spleen. And first of all, you do all the you cut all the ligaments by the laparoscope, with the help of laparoscope, by diathermy, and there is a special instrument like Lagashore which can cut and diathermize the ligaments and the attachments surrounding the spleen, and by that you remove the spleen and ligate the splenic vessels, and then do the splenectomy and take that spleen in this bag and crush that spleen, and then you can remove the spleen by the supraumbilical port, as this is shown in the picture. Common complication of both methods, like laparoscopic or the open method, is post-splenectomy sepsis, increased incidence of pneumonia, septicemia, meningitis, because as we have discussed, all encapsulated foreign organisms, the patient would be prone. So post-splenectomic sepsis could be prevented by giving the prior vaccination to the pneumonia, Neisseria, meningitis, and other encapsulated organisms in order to prevent the post-splenectomy sepsis. Overwhelming post-splenectomy sepsis, it is about 0.8% in adults and high in children. So in all the patients, there is one thing which could be done for the patients of those who are prone to having overwhelming post-splenectomy sepsis, especially the children. You don't do the splenectomy, but you try to save the spleen. So that procedure is called the Spleenomegaly. So rather than removing the whole of the spleen, if you can able to protect the spleen, or you can able to, you can say, prevent the spleen from removal or splenectomy in the method. Suppose your patient is having a damage of the upper pole of the spleen, and rest of the spleen is normal, and the splenic vessels supplying is not injured. So you just do the remove the upper portion, and you can ligate with a absorbable suture, or you can apply a mesh over it, and or you can apply a omentum over it, and then you can save the spleen by this method, which is called a splenomegaly. Sometimes the spleen is having in a pieces of 3 or 4, but the splenic hilum is intact, the splenic vessels are intact. So in those cases, what you do, you can apply a mesh, the prosthetic mesh could be applied over that, broken segments, and you can take that wrap over that spleen, or you can apply a omental wrap over that 2 or 3 pieces of spleen, and you can save the spleen by that method. So this overwhelming post-splenectomy sepsis could be prevented, especially in the children, because children are prone to have a sepsis. So in those cases we try to save and do the utmost for our children to save the spleen. Thrombocytosis, yes, once you remove the spleen, there is an increase in the platelets count. So if that is there, the thrombocytosis occurs, then the chances of DVT and pulmonary embolism could be there. So what you do, just monitor the platelet counts. If the platelets count goes more than 7 lakhs, or if it goes more than 5 lakhs to 7 lakhs, then this is an indication where you can start the heparin, or you can give the treatment of the DVT to your patient. Post-splenectomy care, like you have to give a tetanus 1 dose, human papillomavirus 3 doses, measles, mumps 2 doses. This is especially for the children's, varicella, zoster, influenza. All those vaccination could be given to your patient in order to boost the immunization of your patient. Antibiotic prophylaxis should be given, and to prevent the overwhelming post-splenectomy infections. Penicillins given for 2 years after the splenectomy in children. So regarding the spleen, if we go and see the absolute splenic indications, as we have discussed, these are the spherocytosis, massive splenic trauma, and the primary. We have discussed the main splenic trauma because mostly our patient, for the commonly or generally the patient who are coming with a splenic trauma, we are doing more splenectomy in the cases of trauma than the cases of spherocytosis or ITPs or splenic malignancies or bleeding varices, because these are very rarely the patients are referred from the medical units to us, where they think after all the medication the patient is not responding, so they send those patients to us for a splenectomy. But as a surgical emergency, the most importance of the absolute indication of splenectomy is a massive splenic trauma, and that we know that how the patient will be presented. That we know that your patient will present with a lower left side rib fractures, or there would be a bruising over the left costal margin, or there would be less patient will not be using that part of the ribs, and so the patient would be having you can say difficulty in breathing, and there will be tenderness all over the abdomen, and the Keher signs, the pain in the left side of the shoulder, is an indication where you think that your patient is having a massive splenic trauma. So if your patient is having a massive splenic trauma where the indication of splenectomy is there, you can do the splenectomy, and you have to do the splenectomy by open method, because if you do the laparoscopy, then the chances would be that you might miss some injuries. So it's better to do the open method of doing the splenectomy than the laparoscopic method. But all other cases where the elective splenectomy we are doing, we will going to use the method of laparoscopic methods. We have discussed the laparoscopy. In both the methods, we have to mobilize the spleen by removing the surrounding ligaments which are there, and that could be done with the help of laparoscope or by the open method. We can take the spleen in a bag and then we crush that spleen and remove that spleen through a through a nylon bag by the supraumbilical port, and by that way we can able to do the. And the advantage of splenectomy, we have discussed the laparoscopic one, are that the patient could be having a less respiratory complication, the patient would be having a less pain, cosmetically acceptable incisions, smaller incision about 5 to 10 millimeter at the umbilicus or on the left and right hypochondrium, and the patient could be having less chances of DVT, less chances of pulmonary embolism. Patient can resume the activity earlier than the open methods, and there would be a cosmetically acceptable scars. And if we see the advantages of the other advantage of laparoscopies are that the patient could be having the most importantly, the patient would be having a less general complication as well as local complication with the spleen. We have discussed the common complications like post-splenectomy sepsis and overwhelming post-splenectomy sepsis. Especially we have discussed in our children that our patient would be having a very common infections are there, so that could be prevented by, first of all, we try to preserve as much as spleen which is possible, and that could be done by different method as we have discussed, like with the wrapping the spleen if it is in the pieces but the hilum is intact, in the momentum, or in a mesh which is absorbable meshes which are available in the market. And we can do the if suppose only the poles of the spleens are damaged and rest of the spleen is fine, just we can take 1 or 2 buttress sutures and apply omentum over it, and by that method we can do the splenography in those patients. So we can preserve the spleen rather than doing the splenectomy. We can prevent the splenectomy by these different methods. We have discussed different vaccinations are required for patients, especially for the children's, like tetanus, measles, mumps, rubella, varicella, influenza, zoster, pneumococcal, and hepatitis A, B, and meningococcal doses should be given to your patient. Antibiotic prophylaxis, it has controversial, but in children especially, long-term antibiotics are advisable to prevent the overwhelming post-splenectomy infections. Penicillin could be given for 2 years after splenectomy, especially in the children. So this is all about the splenectomy. As I have discussed that this is a more splenomegaly is a topic of medicine, but we have discussed the splenomegaly in regards to the surgical intervention. So this is all about today's lecture, and stay at home because